Okay, hi everybody. Let me just talk quickly about our objectives. We're going to work on recognizing disruptive and problematic behaviors in children, including diagnosable disorders that might be causing those behaviors. We're going to talk about how to provide behavior management guidance to parents. That's what we do most of the time. We're going to describe psychosocial treatments for disruptive behaviors and disruptive behavior disorders. And then at the very end, we'll identify some medications that could be useful that are both sort of symptom and diagnosis specific when possible.
So what exactly do we mean by disruptive behavior? And it's such a big label, and sometimes you'll hear synonyms like oppositional or defiant or non-compliant or aggressive or violent. And this can span normal toddler behavior to criminal behavior by teens that like lands them in jail or in other kinds of trouble. So, but within this big umbrella, there are certain diagnosable conditions that the DSM specifies. So oppositional defiant disorder is probably the most common, the best known. And basically, it's a pattern, a recurrent pattern, just like really irritable or angry behavior that's defiant, that's argumentative, possibly vindictive, and that this is happening for at least 6 months. Conduct disorder is like that, like taken much further, where the behavior becomes violating of the rights of others and societal norms. And this is, again, a chronic pattern, not just something that happens like during an adjustment period, but a chronic pattern of this kind of norm violation. There's a disorder called intermittent explosive disorder that we should all hear about if we haven't heard of it already. But these are more severe recurrent behavioral outbursts occurring with aggression of some kind, generally physical aggression, property damage, or some kind of physical assault. And this has happened at least 3 times in 12 months. And so if behavior gets truly explosive like this, and it happens in a recurring way, intermittent explosive disorder is something to think about. Many times you have like significant disruptive behavior doesn't quite fit into any of these DSM categories. It's something more than kind of normative, kind of developmental stages that younger children might go through. Kind of looks like some of these other things, but doesn't quite fit criteria. So that's kind of the other unspecified. But this kind of behavior, disruptive behavior, is often seen with other conditions, very commonly ADHD, but sometimes mood disorders can show up this way. Sometimes anxiety even can promote this kind of behavior. Definitely trauma or PTSD can lead to behavior that looks a lot like this. And so because these are the things that we're thinking about when we're thinking about disruptive behavior, the very first thing we've got to consider is safety. Is the child safe? Is there maltreatment, neglect, or abuse going on? There's substance abuse either in the family or engaged in by the child, right? Especially as they're getting into their adolescent years. And is this youth a danger to others? So when we see significantly disruptive behaviors, we want to do the safety check first. We've got our screening tools that will help us to figure out, is this kind of more normative? Is this a bigger cause of concern? I don't know how many of you guys here are familiar with the SWIC. Like, quick show of hands, like has anybody used this survey for well-being in young children? Okay, it's a developmental screener tool, but it also includes a version of the pediatric symptom checklist, but it's been adapted for like younger ages, preschool, even like toddler years. And so, so the SWIC will often get at these questions, as well as some developmental milestones, autism screener questions, family stress questions. There are some questions that get at to caregiver depression, intimate partner violence, other stressors. And so it's a great combined screener that I think is great, like when you're thinking about behavioral conditions in younger children. For the school age kids, we're all familiar with the Vanderbilts, I believe. It definitely has those sections that get towards the oppositional defiant disorder, the cognitive disorder, as well as the PSC, the externalizing category is what will pick up this kind of behavior. But when you're looking at younger children who are acting in this really disruptive way, who are on the verge of being kicked out of preschool, maybe their second preschool, it can be very hard to figure out what is going on. Is this kind of the normative, kind of like disruptive young kid stuff with maybe added on like a particularly challenging temperament, parent-child dynamics, making things worse? Or is there an emerging disorder here? Are these the first signs of a neurodevelopmental condition, like autism spectrum disorder or like severe developmental delays? So younger kids in particular can be a little bit like challenging. And so to figure out exactly what's going on, but just wanted to point out like how, the special conundrum that they might pose. Or it could be like nothing diagnosable, but still of great significance to parents.
Okay, hopefully everybody can see this slide, engaging parents. I just had a little flicker of connectivity issues. This is what we do in pediatrics and child psychiatry. We engage parents, right? Sounds so easy. If only it were so easy, because there's a real important need in addressing parent resistance, or what we'll call the oppositional defiant parent. And parents can be resistant for lots of reasons, lots of good reasons. They'll be defensive, they'll feel blamed. They'll push off the blame on the child or the school. Obviously, there's a lot of stigma with behavior. It can be quite embarrassing to them when it happens in public. It can be embarrassing to get calls and have to go pick up your kiddo from school. Sometimes when we try to talk about interventions, we'll hear, or it'll feel like the parent's saying it's not worth it, but I tried that already. And we have to keep in mind that they may be burnt out, or they may be experiencing a diagnosis themselves. Maybe they're depressed or anxious or something. So like anything, we want to validate. We want to let them know that we hear them and we understand that it's really hard. Letting them know that it makes sense and it's been difficult in working with their child because their child's challenges with XYZ. If you have a diagnosis, or you can just name the behaviors that the parents told you. That gets to the hard sell part, that really it's the parent level interventions that have been shown to make the biggest difference for kids and adolescents, even helping them understand how their behavior affects their child's behavior and mediates how their child learns to deal with frustration. This can often be done if we remind them how much effort they're already putting in right now in terms of putting out fires and dealing with all the difficulties that their behavior is causing. And so by putting in the effort to help modify their behavior and help their child, they'll be more likely to address it, sort of paying it forward. Or pay now or pay more later is what I like to say.
As Neal mentioned, that it's the parent level intervention that makes the biggest difference. And so if there's a treatment for disruptive behavior, it's basically training parents in how to manage the behavior of their children. So parent behavior management training is a thing, and it's a special, like, known psychosocial type treatment. And the better we know the basic principles of it, the better we'll be able to help our patients that have disruptive behaviors. So out in the community, you'll hear like labels like triple P, positive parenting, incredible years, the Kazan method, 1, 2, 3 magic. So I'm sure we've heard some of these around. These are all different forms of parent behavior management training. For older kids, functional family therapy or multi-systemic therapy will take some of these principles, but more like adolescent friendly and more geared towards really the problem conduct disorder type behavior. And not only for disruptive behaviors like what we're describing here, but also for ADHD, parent behavior management training has a pretty solid evidence base that it can be helpful. That's a lot of work. It's a lot of work for the parents because it means the parents have to change their behavior. But whatever the brand name that you send parents towards, if you're lucky enough to have these resources in the community, they all kind of run on very similar principles. So immediate use of praise, specific praise for behavior, like right afterwards, to help reinforce the positive behavior. Other positive reinforcers that can be used besides praise, whether it's little tokens or like stickers or whatever. Different kinds of environmental strategies, and you'll get into more of like how that might look. But it really has to do with like what triggers the behavior and what follows the behavior, and how can we modify either the triggers or the responses to modify behavior. There's certain parenting tools, things like special time or time in, use of timeout, token systems or other kinds of incentive systems. And when consequences get applied, for it to be calm and consistent, calm, immediate, and consistent. These are the basic principles that all of these programs kind of revolve around. And we're going to get into a little bit more detail.
So a great way to get into more detail about how these principles work and an approach to helping parents learn them is through the Incredible Years Parenting Pyramid. This is my favorite slide. I'm so glad I got to give it. On the bottom, you can see the base of the pyramid is the parent skills and strategies that we're trying to develop. And to the right of that are what they directly do to benefit the child. And so the bottom is very loaded on connection and play and empathy. We're trying to help better problem solving, better cooperation, improve social skills, motivation. And so that's a big dose is on the bottom. The medium dose in the middle is we're trying to help parents be more consistent, to follow through, so that the child can know what to expect and what not to expect. Then we get to the very end, the very tip of the pyramid, and it's more of extinction, ignoring, that works well with annoying behaviors. And eventually, selectively, we want parents to use timeout, loss of privileges, or natural and logical consequences. So you can see there's a natural flow at the base towards more positive, empathetic, connected approaches that we want to use liberally. And at the very tip, okay, there are consequences. We're going to have to give you some space or timeout, or you can't have screen time now because we lost that privilege. But this is almost an inversion of a lot of parents' natural tendency. That's why I like this slide so much. They naturally go straight to consequences. Oh, you can't do that. You've lost. Game over. You blew it. And what does that lead to? More aggression, more reactivity, more disruptive behavior. And so that's why helping parents understand to start with the base with praise and positivity is so important.
So one of the ways we can build up the base is with special time or time in. And the common mantra being timeout's more effective if there's been a lot of time in. And special time is just basically you schedule times for undivided parental attention. It could be 10 minutes a day, it could be 15 minutes a day. But the thing is, it's scheduled and it's sacred. You have a good day, you have special time. You have a bad day, you have special time. It's undivided parent attention. Phones are gone. Other tasks are gone. You are not doing chores together. You're not doing like household tasks together, but the child is picking a fun activity that both parent and child are doing together. And the whole point is really to have fun and to enjoy each other's company again. And it builds up that base, that attachment, that connection. And what it tends to do is increase a child's motivation to try some of this harder stuff around behavior modification. This is almost like money in the bank, right? Every time we scold a child, that's money out. Every time we have to apply consequences, that's money out. This is money in the bank. And when there's a lot of this special time, when there's more of this connection under the belt, child's motivation to try harder towards positive behavior, it increases. And I also find that it doesn't fix everything. It doesn't make all the problems go away, but it tends to lower the temperature. If there's just been so much conflict and just a lot of just like between the parent and child because of all this like challenging behavior, the temperature lowers and they find that the outbursts are less frequent and a little less severe. And that creates a lot of great, like important breathing room.
And with that breathing room, there are some approaches that help you as a clinician, but also help parents understand the intricacies of behavior and where it's leading, where it's coming from, and what to do about it. And so ABCs, or functional behavioral analysis, is something I learned from some psychologists that I had worked with And I started trying this a little bit with parents, and I think it helps. And it just helps me understand the behavior better too. So the A stands for the antecedent. So here's a classic example. Mom says no to buying a toy at the store, at Target. Then the behavior happens. Child screams and throws a fit in the store. We've all seen this happen. It's happened to many of us ourselves. And then there's a consequence. Mom calms down. The child, oh, I'm so sorry, he promises to buy the toy, which results in the child and parent negatively reinforcing the whole thing to happen again and again and again, like Groundhog's Day. Child's figured out if they throw a fit, they get it. Parent feels mortified, they feel embarrassed, they feel kind of hopeless. How do I get out of this trap? And so helping them think about, well, what could have gone differently with communication or communicating to the child what we really want to get out of the experience, and why was the child seeking attention in this way. So we'll drill down a little bit more and think about this example. In the functional behavioral analysis, I'm just trying to help create better outcomes. So the first piece is helping the parent thinking about, well, the environment to begin with. What really caused this and affected the child to become so dysregulated so quickly. Helping the child learn to name their thoughts and feelings in time, in the moment, will be helpful. Giving them clear, concrete instructions about what's expected and what's not expected will be helpful. Of course, staying calm will be helpful. Increasing structure. Some parents will be like, all right, this is our list. You're going to help me find everything in the store. Today we're not stopping in the toy section, but we will grab a snack on the way out. Sometimes modifying the demands are really important. It may even be just a mistake to go to the store with the child. Sometimes I'll have this conversation with parents. It's like, do you really have to take them? Do we really even have to open up this Pandora's box? And sometimes they do. They don't have a choice in childcare. Other times they're like, no, actually, I could leave them at home with somebody else, and it would be fine. And that works. And then, of course, getting down the list, special time. If we'd lowered the temperature to begin with, this may have been less likely to happen. Ultimately, the goal is to help the child self-regulate better. And so it could be that the parent would help the child more if they gave them something to play with that they could take into the store to keep themselves busy. It could be that in the moment, positive feedback. Oh, you're doing such a great job. You're being a great helper. You're going to help me find this next thing we're looking for. Keeping them engaged will help them not get fixated on having to have a toy.
And so the C was the consequences. Just basically what happens after the behavior. Will the behavior get reinforced, which means the behavior will increase? Will the behavior get extinguished, meaning it tends to decrease? So basically, to increase behaviors, you want something that reinforces it, something that rewards it in some way. So immediate praise for the positive behavior. Attention tends to increase behavior. So I saw this out of one of the AAP guides where behavior plus attention gives you more behavior. So the behavior you pay attention to is the behavior you're going to get more of, whether that's praise or whether that's yelling. If you're paying more attention to that behavior, the tendency is for that behavior to increase, to get reinforced. So the mantra that comes out of this is one that we often use is catch them being good. Right? It's just super easy to catch kids being bad and just only to pay attention to the kids when they're misbehaving in some way. But then they end up getting inadvertently reinforced for that negative behavior because they get a lot more attention if they act out. So we want to flip this. So they get more attention, they get more of what they need, more of what they want if they're behaving in a more positive way. Now, other positive reinforcers besides the praise and the attention would be like incentives or tokens, but it's got to be immediate and it's got to be consistent and periodically changed up so they stay fresh and not boring. Conversely, you could try to decrease certain behaviors or extinguish them in some ways, and this is like where planned ignoring comes in. So if it's annoying, but it's not harmful, and you don't want to see more of this, just planned ignoring. consequences for the things that you just can't ignore because they've, there's a prospect for harm to somebody else or themselves. So timeout, losing privileges on those lines.
Okay, so here's the bottom line with a lot of these procedures, techniques that we're trying to teach parents to do. It often gets a little worse before it gets better. This is sort of the classic extinction graph we've seen in lots of situations. There's the initial behavior response frequency, there's the intervention, and then the child pushes back. And that's when the parent's like, why did I listen to Dr. So-and-so? This is really hard. And then if they consistently keep doing it, you get the extinction, you get stuff getting better, and you get some recovery. And there's some, obviously some blips down the road. But it's very important with anticipatory guidance to let parents know that it often gets a little worse before it gets better. If you don't tell them that, they're likely to bail out, right at the peak of the extinction burst.
So, all right. So we talked about disruptive behavior, and when it's something that kind of falls more into this disorder and needs to be treated, this sort of psychosocial treatment is the first line. Okay, so that's the parent behavior management training. It's instituting some of the things that we just talked about, or individual psychotherapy for the child, especially if we think there might be some mood disorder or some trauma or stress that's underneath it. And then using special time. So psychosocial treatment always comes first.
And then there's the use of medications. It's very tricky when I give medication talks to the residents at UCSF. It's very tricky to line meds up with diagnoses. It's probably more helpful to line them up with symptoms, in particular types of dysregulated or disruptive behaviors. Of course, we're all taught as pediatricians, and if ADHD is present, medicines can be quite effective. And first-line therapy stimulants that can often allay a lot of the disruptive behaviors in a child, but at the same time, it will buy the parent some time because they're connecting more. The child's more focused. If they're connecting more and they're utilizing some of the techniques that we're helping them with, they're teaching more. They're able to praise. The child's able to register the praise. Calm down and feel good for a moment. For other maladaptive, repulsive, or aggressive behaviors, obviously there's lots of other meds out there. That's a whole nother lecture. In my practice, I typically use a lot of alpha agonists. Occasionally I have to use atypical antipsychotics. I rarely will use mood stabilizers because that's for child psychiatry. But thinking about meds when the temperature is too hot for anyone to be able to basically swim at all, to get anything done, I think it's important to be able to do that and have some ways to reduce symptoms, and by that diet between parent and child, some breathing room, some time to work on skills.
So these are just a few resources and books that might be helpful for families with children with some disruptive behaviors, as well as some websites that might be helpful. These will be in the handout that I'll email out later. I just wanted to call your attention to it now. And real quick, one question did come up in the chat about the distinction between FBA and ABA. Neal, I know you typed something, but if you just want to quickly summarize.
Yeah. A lot of these TLAs, these three-letter acronyms, get thrown around and they're very confusing. Sometimes we use interchangeably. And I'm just going to give you my own best sort of practical, functional way of thinking about them. ABA stands for Applied Behavior Analysis. It's a technical approach that's based on classic behavioralism. We're just trying to associate something positive with this behavior we're trying to get you to do. Basically, we're giving kids, treats or stickers or stars for little trials of things we're trying to get them to do. It's used a lot in autism, and an FBA is used oftentimes in schools. It stands for Functional Behavioral Analysis, trying to figure out, well, what's the behavior trying to do? Just like that child in the store, they're trying to get attention, or they're trying to get the toy, what are they trying to do with this behavior? Sometimes you'll see it part of a behavioral support plan. They have to do an FBA to get the BSP in order to figure out what they're going to do to support disruptive or problematic behaviors for a kid in the classroom. We'll see now with new patients who have IEPs.
Thanks, Neal. And real fast, one more question. And this one came from Darcy. If using planned ignoring, does that include having a discussion beforehand that the parent will ignore behavior X when it occurs? Then concerned that it can also be confused with not validating the child's experience.
This is the ultimate judgment call for parents, right? That child's down on the floor crying. Are they crying because they're having pain? They're having dysphoria. Something's wrong. Acknowledging that empathetically feels like the natural thing for a lot of parents to do. And when it's clear that there is some pain, I think it's important to be empathetic and acknowledge it. But then also to pull back and allow the child some recovery. Like, oh, it looks like you fell. Looks like you're okay. And then wait for the child to get up. And if they don't get up, you want some help? Okay. Whereas the planned ignoring is for repetitive, annoying behaviors. Okay. The nagging, the badgering, letting the child know ahead of time. So I've already told you we're not going to get a toy in the store. Okay. And I know that's going to be hard. You might want to ask of me all over and over and over and over again. And so I'm not going to say yes. Okay. So if I'm not saying anything, that means no. But we can do these other things. We can do these other fun things. Okay. With our time in the store together. Okay. That's hard. Kids aren't going to kind of process that cognitively until they're 7 or 8 really well. So sometimes the more sensory, the more distracting approaches will be more effective.
Thanks so much, Neal.